Good afternoon, ladies and gentlemen. At the outset, I would like to thank the organizers for giving me this opportunity and for the nice hospitality we are enjoying here. I have been given the topic of pituitary incidentalomas. One of the organs where incidentalomas are pretty common after thyroid. So, I will be going about in the following order. First, deal with three case scenarios. I'll introduce this topic. Then go on to broad classification with regard to pituitary incidentalomas and the approach to them. The follow testing to be followed with these and the indications for surgery in these cases, and finally summarize the talk. The first case scenario, we have a 25-year-old woman with chronic headache, non-specific headaches, and for her MRI was done, and it showed a 5 millimeter adenoma. And except for this, she is completely asymptomatic. She has normal menses, and the physical examination is also normal, and there is no galactorrhea. This is one example of a pituitary incidentaloma. We'll see how we manage it. This was MRI, both the sagittal and coronal sections of post-contrast even-weighted images. And this is the second case scenario. A 49-year-old man with history of type 2 diabetes and hypertension. He had MRI done for multiple episodes of tingling in his right arm and leg, and that incidentally picked up a 1.4 centimeter lesion in the region of sella, abutting on optic chiasma, and it was consistent with microadenoma. He is otherwise asymptomatic and has normal sexual function. There are no clinical signs either to suggest acromegaly or Cushing's disease. So this is yet another scenario which we have. Just this is a macroadenoma just abutting on optic chiasma. And we have a third scenario. There is a 28-year-old lady who on antipsychotic drugs who presents with 3 months amenorrhea, preceded by a year of oligomenorrhea. She has a prolactin of 58 nanograms per ml, the normal being 5 to 25. The MRI pituitary shows a 3 millimeter microadenoma. Your doctor diagnoses her with microprolactinoma. Whether we all agree with the diagnosis of microprolactinoma in this scenario? So, actually, this is yet another incidentaloma. History-wise, we will have to analyze and come to a diagnosis. I will just deal with this again. So, what is pituitary incidentaloma? The pituitary incidentaloma is a previously unsuspected pituitary lesion that is discovered on an imaging study performed for an unrelated reason. Here, we should take care that the imaging study was not done for a symptom specifically related to the lesion. This should be taken care of. Then we can diagnose pituitary incidentaloma. As such, we all know it's a byproduct of modern technology, and thing to be remembered, it's neither a distinct diagnosis nor a pathological entity, and just a collective designation for various diagnostic entities discovered by chance. We know that in the general population there are about 100 cases of pituitary adenomas, of which nearly 15 to 35% constituted by non-functional pituitary adenomas. How these non-functional pituitary adenomas manifest? This will be either in the form of symptomatically they will present with some mass lesion, and if they are asymptomatic, they are incidentally picked up, and these constitutes the pituitary incidentalomas. Most of the pituitary incidentalomas will be constituted by these non-functioning pituitary adenomas. When you come to prevalence, we can either study prevalence from the autopsy studies or from the radiological imaging. From the autopsy studies, it varies from 1.4 to 27%, and from imaging, it can vary from 3.7 to 37%. And grossly, we can divide it into macroincidentaloma and a microincidentaloma. And whatever we see commonly as incidentaloma is just microincidentaloma. Nearly 80% of the microincidentalomas will be less than 3 millimeters of size. And it's important to make a distinction in the microincidentalomas into two categories: those less than 5 millimeters and more than 5 millimeters. This is, I will come to why that's important. What are the differential diagnoses for the pituitary incidentalomas? Majority, nearly 90% will be constituted by the pituitary adenomas, and the rest will be the other differential diagnosis, of which again the most commonest, if you have to see, it will be the rat case clefsis. The natural history of the pituitary incidentaloma, we have not much literature on this, and the literature is scarce. And there is when it comes to microincidentalomas, we have to note that there is an insignificant change with time in the size of microincidentalomas. When it comes to macroincidentalomas, it has been noted that with time, in 4 to 8 years follow-up, they have noted a variable increase from 20 to 24% at 4 years and 34 to 40% at 8 years. And in natural history, with progression, they have found that the progression to pituitary apoplexy amounts to around 0.6 cases per 1,000 patient years, and visual field effects in 0.6 per 100 patient years, and endocrine dysfunction in 0.8 in 100 patient years. We come to the guidelines. What do the guidelines say with regard to pituitary incidentalomas? This is the most important thing. Actually, there is a distinction between, there are two main guidelines which I have referred to, and one is the Endocrine Society guidelines, which had come up in 2011, and the other is 2015 French Endocrine Society consensus guidelines with pituitary incidentalomas. More practical one is the French Endocrine Society incidentaloma consensus guidelines, which quotes in non-functioning pituitary microadenomas of less than 5 mm diameter, neither radiological nor hormonal surveillance is recommended. So this can be one practical point which we can follow. And most important point to remember is, first is the clinical assessment of these cases. Because the case 3, I had showed a scenario of a patient on antipsychotic drugs with a prolactin value of 58. People will take that as a functioning tumor. But we have to take a nice detailed history, and that is actually drug-induced hyperprolactinemia. And whatever was noted on imaging was just incidental pituitary adenoma. So the first important thing is a complete history and physical examination, and followed by evaluation of hormone hypersecretion. So anything of hyperprolactinemia, anything of menstrual irregularities, anything of galactoria, or anything suggestive of Cushing's or acromegaly, any history, subtle findings suggestive of these entities should be looked for. And when we don't have any symptoms, and we have we have noted this by imaging, then we can consider the diagnosis of pituitary incidentaloma. And especially with regard to macroincidentalomas, additionally we will have to look for signs of pituitary hypofunction. Till now, in the when it comes to microincidentalomas, we mainly concentrate on hyperfunction. When we come to macroincidentalomas, we have to concentrate not only on hyperfunction but also on hypofunction. So check for signs of hypopituitarism and also for tumoral syndromes suggestive of high intracranial tension, of headaches and compression symptoms due to chiasma compression. So hormonal evaluation will mainly, when it comes to microincidentalomas, anything more than 5 millimeters. I have to say that in the Endocrine Society guidelines, they don't make a distinction between the size, anything more than 5 or less than 5. When it comes to Endocrine Society guidelines, for all the microincidentalomas, they advise a check for hyperfunction. So predominantly, practical thing to do for a microincidentaloma would be to do at least a prolactin and IGF-1. And for macroincidentaloma would be to do, in addition to all these, thyroid function, FT4 and TSH, cortisol, testosterone, LHFSH, to document hypofunction concomitantly. Another point to be noted is this I just alluded to some time back. We need not check for anterior pituitary insufficiency in a case of microincidentaloma, but nevertheless, we have in Endocrine Society guidelines of 2011, they have suggested that in those with 6 to 9 millimeters, we may check for somatotrough, that is growth hormone insufficiency, if we are likely to give growth hormone replacement on detecting it. So, concomitantly to be followed is the ophthalmological evaluation. So, this ophthalmological evaluation is only advised for macroincidentalomas and not for microincidentaloma. So, initially you start off with visual acuity testing, followed by visual field charting for those enlarging pituitary incidentalomas which are abutting or compressing the chiasma. Additionally, in these cases, optical coherence tomography, the OCT, is contributive. They may give a prognostic significance as to whether the site is recoverable on removal of the pressure symptoms. Follow-up testing with pituitary incidentaloma with no indications for surgery. When it comes to the Endocrine Society guidelines, they said that clinical and radiological follow-up can be divided into those for macro and micro as follows. With regard to macroincidentalomas, we are advised to repeat the MRI at 6 months. If at 6 months it is unchanged, we are encouraged to repeat the MRI every year for 3 years and less frequently thereafter. If on the other hand, there is a slight increase in the size in between, then we will have to take clinical judgment and do the follow-up at a lesser interval as the condition requires. And when it comes to microincidentaloma, we are advised to repeat the MRI at 1 year, and if it remains unchanged, we can repeat it every 1 or 2 years for 3 years and less frequently thereafter. What are the indications for surgical therapy of pituitary incidentalomas? These are the recommended indications. There are two recommendations Endocrine Society gives. One is the those in which they recommend, and there are few indications for which they suggest. So these are the ones wherein it is recommended. That is visual field defect due to the lesion, the visual abnormalities such as ophthalmoplegia or neurological compromise due to compression of lesion, or lesion abutting or compressing on optic nerves or chiasma, or pituitary apoplexy with visual disturbance, and hypersecreting tumors other than prolactinomas. And these are the indications for which surgery has been suggested. Those are clinically significant growth of pituitary incidentaloma, loss of endocrine function, lesion close to optic chiasma, and there is a concomitant plan on behalf of patient to become pregnant, and there is an unremitting headache. These are suggested indications for surgery for incidentaloma. So, as such, to summarize, pituitary incidentalomas is a collective designation for pituitary masses discovered by chance. In a pituitary incidentaloma of less than 5 millimeters diameter, neither a radiological nor hormonal surveillance is recommended. Majority of the pituitary incidentalomas, especially microincidentalomas, conservative management would be treatment of choice, and main indications for surgery involvement of optic apparatus, endocrine dysfunction, ophthalmological symptoms, and progressive increase in size. Thank you.